Welcome to today's session, sponsored and put on by the East Texas Geriatric Education Center, addressing difficult topics in aging and disease. This is session 3 that will focus on everything you need to know about cancer. I would like to acknowledge our partnership with the East Texas Area Health Education Center East that have been really valuable in terms of our collaboration and distribution and connections with our consortium partners in East Texas. Okay. This is, as I said, the third session. It's in a series of 4 dealing with these difficult topics. And when you want to look at it, it is really about challenges to working with older patients and disease processes. And we will have our final session on the third Wednesday in May 16th, looking at modeling long-term care that will focus on nursing home residents and older prisoners. And we hope you can make it then as well. This will be a very short introduction because we have a lot to do today and a lot to fit in 3 hours. And everything is in your handouts, so I'll just briefly go over this so we can get going here. You have your agenda here with our 5 speakers, and this will cover the whole gamut of cancer care with an overview of basically epidemiology of cancer given by Catherine Coaxley, then looking at screening with Dr. James Goodwin, treatment of cancer with Dr. Holly Holmes, a short break, and then to kind of go along with treatment, what about overtreatment or aggressive treatment? And this will be given by Dr. Gulshan Sharma. And finally, with Dr. Linda Elting, supportive care, not just for treatment for end-of-life care, but this new wonderful area of survival of cancer. Okay. And this will also be set up now as a webinar, and I will give you later on, those that are connecting as a webinar, the number to call in for questions and answers. Okay. The whole day has a list of learning objectives, which are listed here and in your handout. And we teleconference to our 5 of our consortium partners in Lamar, University in Beaumont, Stephen F. Austin in Nacogdoches, Baylor University in Waco, Victoria College in Victoria, and Weatherford College in Decatur. Okay, there's lots of information available for CME. These are all free credits for doctors, nurse practitioners, and physician assistants. I need to disclose that all except Dr. Linda Elting have no commercial financial interests or affiliations to disclose. Dr. Elting discloses the following relevant financial relationship with Helsinn Pharmaceuticals in terms of having grant and research support. And the same for nursing with CNE, similar disclosures, and all the paperwork evaluation forms are in the back. Okay. Physical therapists, we have CEUs available as well as for occupational therapists. This is really about CERSIT, Comparative Effectiveness Research in Cancer Cancer in Texas, and all the speakers are affiliated with CERSIT. And you can find out more about this work being done, this collaborative work, which has been wonderful because we've been bringing in other researchers from MD Anderson, Rice University, University of Texas School of Public Health, and Baylor College of Medicine, and the Texas Cancer Registry.
Okay, so I'm going to talk about screening for cancer in the elderly. Oh, it says elderly, cool. What I'm going to be talking about is really a generalization of issues that providers have in dealing with older patients. What we've realized over the past 20 years or so, I think some clinicians have always realized it, but I think we've finally begun to come to grips with it in terms of trying to shape policy, is that if we willy-nilly was one of my mother's favorite phrases, keeping with the theme of aging, and apply rules that we develop based on trying to think of the best care for 50-year-olds. If we just apply them to 75 and 80-year-olds, we can cause an enormous amount of harm. And not only didn't we realize that in terms of public policy, it was more than we didn't realize it. We would go around and sort of reflexly scream ageism if something wasn't done in these populations. In other words, we would find a rule like, oh, you got to get a hemoglobin A1C every 3 months. And that would be, you know, an okay rule. I don't even know if it is every 3, every 6, whatever. Anyway, that you have to do it in diabetics. And it would be a perfectly fine rule for 50-year-olds. But then when you applied it to, or you had to keep the hemoglobin A1C under 7, would be probably a little more relevant. If you apply that to 80-year-olds, it just winds up to be rather stupid medicine. And it took a long time for us to realize that, because we were grading physicians based on information like that and stuff like that. So similarly with cancer screening, we've realized that some of these rules don't work, or we're slowly realizing. So in terms of, first of all, what is screening, okay? So in order to have a screening test, you should have a serious disease. You shouldn't screen for the common cold. It should cause a lot of problems. And you have to have an effective treatment. Otherwise, it's silly to screen. And these are all sort of, you know, all critical, all necessary. You have to show that diagnosing it earlier actually matters. In other words, if you diagnose it earlier, that the treatment has a better outcome. Otherwise, you're just giving people the disease longer before they die. You know, if you're going to die in 2020 from a disease, and I screen and diagnose it now, then you've got 8 years to live with your disease. If instead we wait until it pops up in 2017, you only have 3 years to live with your disease. If the screening doesn't lead to easier or more effective treatment, then you can't screen. And there are some examples of that in cancer screening. And then the screen should be simple, sensitive, and reasonably specific. Specific is a big issue. Specific is, you know, how many people without the disease turn out positive on the test. This is obviously a big issue for mammography, the most common cancer screen. You women look all kind of more on the youngish side, but if it were a slightly older group of women, probably up to about 25% of them will have had a cancer scare, will have had a mammography scare, where, well, we want you to come back for, you know, a few extra tests. Well, things aren't totally normal. Why don't you come back 6 months later for a repeat exam? That was always a great one. Don't worry about it, really, but come back 6 months later for a repeat exam. So that doesn't kill people, but it's a burden that the population has to pay. So another thing is, what is cancer screening? Cancer screening is when you test an individual with no symptoms. So this has nothing to do with getting a mammogram because you have a lump, or getting a PSA because you have trouble peeing, or getting a colonoscopy because you have problems with your bowel movement. That's not screening, okay? And nothing I say has any relevance to that. So what are the current recommendations? And I'm going to be spending time on each of these briefly in terms of where we got to these recommendations and where are we going. This is the U.S. Preventive Services Task Force. This is a group of mostly general internal medicine physicians and experts in public health who are making recommendations on what is the most appropriate. This is American Cancer Society, which has always been the most pro-screening of any organization. So, and these people are fairly conservative. If there's no evidence, they're not for it. These people are very the other end of the spectrum, so that's why I showed the two. The interesting thing is there's over the past few years, as evidence comes in, there's been a lot of convergence. So currently, U.S. Preventive Services Task Force says women should get a screen every other year between 50 and 74, and they're not sure about over age 75. American Cancer still starts at age 40, but interestingly enough, they've put out a couple reports recently saying that they are re-examining this whole issue. This is a very sensitive political issue because there are just waves of cancer survivors out there who are the biggest support for the ACS, and they have to go very slowly. But they've talked about the fact they now understand some of the problems with this approach in terms of overdiagnosis, which I'll get to. And they're reconsidering this issue. Colon cancer, some changes. Basically, what I don't think is understood is that most organizations say, look, if you want to get a stool test every year, that's fine, or sigmoidoscopy, or colonoscopy. The way that's translated to the public right now is colonoscopy. American Cancer Society does prefer a colonoscopy or a barium enema or CT colonoscopy, because those are the ones where you can find the polyps. If you just do a fecal occult blood screening, you're more likely to pick up an early cancer, but you might not pick up a polyp. These people say no routine screening after age 75. So that's good news for people when they get to 75. They don't need any more routine colonoscopies. And remember that. Because there still are a lot of routine colonoscopies being given to people over 75 in this country, and that can only that will cause more harm than good. Prostate cancer has changed, as you probably know. 2 years ago, these people were saying we don't have enough data. They now say we have enough data. Don't screen. Don't screen. Any age. Don't screen. No routine screening. PSA, bad idea. That's going to take a while. It's like one of those ocean liners making a big turn. It's going to take a while for that to sink in. It hasn't sunk in yet, but that's the current recommendation. Even the American Cancer Society, which, as I say, is the most out there in terms of believing in cancer screening, their medical director wrote sort of a mea culpa. There's an African-American man who was sort of beating up on the medical community for under-treating African-American of any type, and said, you know, I now get it. Screening causes more harm than good with PSA. And the American Cancer Society now says, discuss pros and cons if you have a sufficient life expectancy. But that's a big change, and I think they're on their way to coming to this. And I'll briefly review the data why. So issues in cancer screening that any provider has to deal with this is an issue between the provider and the patient. If there is ever a prime example of shared decision making, it is in cancer decisions, because my patients get all the same information I do, essentially. There's no privileged information for me. I have privileged information about how to listen to a heart or the best treatments for congestive heart failure, but they get the information on screening at the same time I do. And the quality is about as good too, as long as they read the right places. This is a place where I'll show you a little data on that, but where it's essentially shared decision making, but there's increasingly where it's just the decision of the individual, and there are some strange beliefs out there. Here's some strange beliefs, and I've shown this before, I think, to similar audiences, perhaps many of you people. But this is an article in JAMA from about 8 years ago, where they did a national telephone survey, and this is just the answers of men who are age 50 and over. And they said, do you think there'll ever be a time when you should stop having the test? No, 73%. Now this is during a time when the American Cancer Society and every other organization, including the urologist, said, hey, when you get over 80, there's no way you can benefit from a PSA. You're just not going to live long enough to benefit, and it will only cause harm, because, as I'll show you later, you'll get diagnosed with cancers that you didn't really need that diagnosis. But still, 3/4 of American men said no, and they're the ones pretty much who have big input on the decision, so that's why that's important. If a physician recommended that this is one sort of discourages me, that you stop having the test, would you agree? Nah, this is important to me, I'm going to have that test. Do you feel an 80-year-old man in average health who didn't have the test was irresponsible? Yes. Now, there's no organization, even in 2004, there's no organization in the world that recommended PSA screening for someone 80-year-old. And yet, not only should they have it, but perhaps they should be arrested if they don't have it, you know? So these are some of the strange attitudes. When a physician is encountering this, sure, you can sit down and educate, but you know, maybe you've allocated 23 seconds to this issue, right? Because you've just dealt with their knees and their heart. And education may take 25 minutes. And so we need better systems for that than just to say, discuss with your physician, because often it's not realistic. So in terms of the benefits, I think everyone understands the benefits of screening. You get it early. And for these conditions, actually, it's not just that you get it when it's more treatable. You actually eliminate it before it starts. So what's happening because of colonoscopy is that the incidence of colon cancer is going down. The number of people with new colon cancer in this country is decreasing every year, just like the number of women with cervical cancer took this huge plummet in the late 30s and early 1940s because of cervical cancer. It used to be the #1 cancer death in women in this country, and then suddenly only 1/10 as many women were getting it because you get that pap smear, and 20 years before it becomes cancer, they notice a little abnormality, scrape it off, goes away. So that can happen with colon too. By removing the polyps, they never have a chance to make it into cancer. The harms are the false positive tests, the mammography being perhaps the most common. Complications of screening or subsequent evaluations, most of these are minor. The major complications are rare. You have to understand, though, that the benefits, and this is something that's very hard for most audiences to accept, the benefits of screening are also rare. Only 4% of people will develop colon cancer. Before we had colon cancer screening, the majority of people who develop colon cancer survived the rest of their lives. In other words, so we're down to, like, 2 people in 100 that screening might help, and then some of those it doesn't help. So in other words, it's not that this isn't a great idea. It's just that when you talk about rare complications, we have to balance it against a realistic estimate of the number of people it helps too. And the one I'll spend the most time on is overdiagnosis, because that's the most relevant for older people, where you essentially bring a person as a gift a cancer diagnosis, where they never would have had that diagnosis. They never would have been diagnosed in their life if you hadn't screened, because they would have lived happily ever after and died of something else. And that's the single biggest burden that we have to worry about when we're talking about cancer screening in the elderly, and why we have either age limits or life expectancy limits on some of the screening. And this also, by the way, is the single biggest reason why no one is recommending PSA anymore, because at any age, this is a huge problem for the PSA test. So in terms of changes with increasing age that should affect decisions about screening, Catherine mentioned that the incidence goes up with age. So if the incidence goes up, therefore the number of cancers you detect for every 100 tests goes up, right? So what that means is that it's a more efficient way to find cancer because there's more cancers to be found. And also some of the performance of the test gets better simply because there's more people with the test. On the other side, you have fewer years to gain. So if you're only going to be living for 15 years and I get a cancer that may kill you in 5 years and I get it so that I cure you, we've gained 10 years, which is wonderful, but it's less than gaining 30 years, which it might be in a 50-year-old. These things matter when you're trying to decide what causes more harm than good. We're not making economic arguments here, we're just making what's best for the population. So the harm is the same, and the potential benefit goes down somewhat with age. And overdiagnosis, I'll talk about for the next few slides, which is when you find a cancer by screening that you otherwise would never have become symptomatic, which means it never would have been diagnosed during that person's lifetime. And the point is that this has been found in the trials of screening. In other words, in order to say that a screening test is good, typically you do a randomized controlled trial. Most of the ones on mammography was done in the late 70s, early 80s. Take 100,000 women. Most of these trials were actually done in Scandinavia, where they had more uniform healthcare systems, and they could come in and do these things. Everyone was covered. Take 100,000 women. You say, we'd like you to start getting every other year mammograms from age 40 to, say, age 70 in most of the trials. Take another 100,000 women and say, we don't know whether it's going to work or not, so we're not going to be giving that to you. It's a national health system, which means you don't get a lot of those women in the non-treatment group going off and getting treatment like you do in this country. So you get a very nice then randomized controlled trial of screening, and that showed that that's why we do mammography, because it showed you reduce breast cancer deaths by about 30%. Breast cancer deaths were about 28%, and then with in other words, 28% of women diagnosed with breast cancer before mammograms, 28% died of their breast cancer, and after mammograms, about 22% did. So it's about a 30% decline in the mortality. But actually in those trials, there was a demonstration of overdiagnosis too. So this is what I'm talking about. And I've shown many of you this slide before, but this is like your lifespan. Okay, you start right now, and there's your lifespan for the next, let's say, 20 years. And right now, even as we speak, there's a little cell that just became malignant. It may have something to do with the lunch, I'm not sure, or even my talk, but it just went pop, okay, and it went bad, as we say in medicine. So it now starts dividing, okay? Yeah, it just divided. Okay, this is a fast-growing one, and so it divides and divides and divides and divides, and a year and a half from now, you're gone. You're history, you're dead, okay? And it divides so fast that within 6 months, it's symptomatic, and then in another 6 months or so, you're dead. All right. So there's very little time to screen for that, and you can't even see it until here. And interestingly enough, and sadly enough, some breast cancers are that way. Particularly breast cancers in younger women are that way, where they go so fast that by the time you pick them up by screening, they're already metastatic, and so it hasn't helped to pick them up by screening. A lot of lung cancers are that way, which is why we've had such trouble over many, many years developing good screens for lung cancer. And then there are the slower growing cancers. And they have a nice long time before they're picked up. Let's just say this is a 10-year period here between when that cell goes abnormal and when it finally crosses this line where you feel the lump, say, in your breast. And somewhere around here is where you get the mammogram. And so you pick it up there at that size, you have a good chance of picking it up, and you have a better chance of then treating it. And then there are cancers that are very slow, that grow very slow, and let's just say you die here. And so here's where it started, and here, let's say 30 years later is where it's going to, well, you don't even make it up there, but let's say 30 years later it's going to kill you, but somewhere in the meantime you die, all right? So this is an awful lot of prostate cancers, which is why we no longer screen, or now why we should not be screening for prostate cancers. And then these are even weirder. the non-progressive ones. There's a lot of, I shouldn't say there are a fair number of carcinoma in situ of the breast and also of the cervix that never progress. Cervix, it doesn't matter too much because the treatment is relatively easy, but breast it does. So same thing, same way of looking at this, except this is specific for mammography. Okay, so here's during the time when you here's where it starts and it's sort of going along and growing, and here's where you can pick it up by screening, and here's where you pick it up when it becomes big enough to feel. And so here's the time that you save in picking up breast cancer. And what that means, by the way, is that in this time between when you screen and when you pick it up clinically, it's not like women are dying of breast cancer, right? Because it hadn't become symptomatic yet. So all of these women are going to survive. And so depending on how long that lead time is, that's during the period when there will be no deaths saved, right? If you die during this period, then you shouldn't have had a mammogram because you wouldn't have died of breast cancer anyway. So more specifically, here's the results of the randomized trial, and here's the death rate from breast cancer after mammogram for the women who got a mammogram, and here's the deaths from breast cancer from the women who didn't get a mammogram. And so what you see is that for the first 5 or 6 years, there's no difference in the curves, and it's not until about year 7 that there's actually a significant difference. So for the first 5 or 6 years after you get a mammogram, you don't benefit from it because you have to live 5 or 6 years in order to benefit, because you wouldn't have died of that breast cancer anyway. It's just slowly growing to the point where you can finally pick it up clinically. And when that's translated, now these are rare events in younger women, that they die, that they get run over, that they get leukemia and all that. But once again, the benefits are not overwhelming either. And so these rare events can sometimes add up. And so when you go back and look at the randomized trials, and I'm sure you've seen publicity about this because it's in the New York Times all the time now. Every time a news thing comes out, and they tend to get published in JAMA or the New England Journal of Medicine, about looking at the older trials from the 80s and trying to find out what's the percentage of women who got diagnosed with breast cancer who, if we only hadn't mammogrammed, never would have had a problem, never would have been diagnosed. And what it is, it's about 20, where are we here? It's about, well, it doesn't say here. It's about a 20% overdiagnosis rate. I'll show you on the next slide. It's about 20 for every 100 women who used to get diagnosed and treated for breast cancer in this country because they had a lump. 20 additional women, 20% higher numbers of women are now getting diagnosed and treated for breast cancer because we're finding it by mammogram. And so the obvious implication is those women, either died or the cancer went away, right? And it's not just an implication. It was because we had these randomized trials with controls, it could be shown. And what it means is that for every breast cancer death we prevent, about 10 additional women are being diagnosed and treated for breast cancer. Now that's a price that most public health authorities are saying that's an okay price to pay. However, it's something that most public health authorities would also say, oh, well, don't tell the public because it's a rather scary figure, that for every death we're preventing from breast cancer, that we are actually finding or creating 10 additional diagnoses of breast cancer. And this is indirect evidence, but it sort of shows the same thing, that when we started introducing national mammography things here, that the incidence of breast cancer rose. It was relatively stable in all these age groups, and then when we started doing routine mammography in the mid-'80s, it went up about 20%, and it stayed up. This drop here was after the study on estrogens, showing that routine estrogens was a real bad idea, and that actually had a very nice, profound impact year to year on breast cancer incidence, stopping routine estrogen treatment. And in the women who you didn't do mammograms in, which is women, say, or younger women where we weren't recommending mammography, there really wasn't much of an increase in incidence over time. So we can calculate this. In CIRSIT, we can get a fairly good estimate of the life expectancy of women based on their age and based on comorbidity, as Catherine was talking about. So here's where I showed you that actually for the first 7 years after your mammogram, there's no significant benefit in terms of cancer mortality prevented. So then you want to live at least 7 years. You want to have a life expectancy of at least 7 years before you decide you want a mammogram. And that's shown here, where we just looked at women of different ages. This was actually using Texas data. And then the number of comorbidities they had, like diabetes or heart disease or hypertension and issues like that. And what we can do is then say, what percent of them do we project to be alive 7 years later? These are data that you don't necessarily routinely share with your patients, but basically it shows that, with a combination of age and comorbidity, you can define a bunch of people who have a life expectancy of less than 7 years. And so here are people with a life expectancy of less than 5 years. Here are people with a life expectancy of less than 7 years. Here's the percent that were still surviving that long. So these people should, I'm sorry, that isn't, that's their mammography percent. These are the people who have a life expectancy of less than 7 years. These are the people who have a life expectancy of less than 5 years. And this is, of those women, how many had a mammogram in the last couple years. And we calculated the life expectancy before they got the mammogram. So this isn't good because these are the women who were going to be diagnosing cancer who otherwise would not have had that diagnosis. So we have to worry about that. PSA screening is a much more extreme example because we no longer talk about how we can't do it in elderly people. We now talk about we can't do it routinely. We shouldn't do it in any man. This is a difficult issue because it takes a long time to change public opinions, and public opinions have really bought into cancer screening. There have been many surveys that show that the general public has much greater expectations of the benefits of cancer screening than do physicians. However, there are also surveys showing that physicians have much greater expectations of cancer screening than they should. The problems with PSA, as I talked about, one of the criteria for getting a screening test is that finding it earlier is better. That's hard to show with prostate cancer. Now we have 2 large randomized trials. The same type of trials that showed us mammography was a good idea did not show that PSA screening was a good idea. And I said that there was a 20% increase in new cases of breast cancer when we introduced mammography. When we introduced PSA, the number of cases doubled. So it's this huge increase in cancer burden. What Catherine was talking about, cancer burden. We brought cancer to the U.S., prostate cancer, by introducing and disseminating the PSA test. This is survival as a function of stage. This is people without prostate cancer. This is people with stage 1 prostate cancer, stage 2 prostate cancer, stage 3 prostate cancer, are all the same. So if you it doesn't matter whether you get diagnosed with 1, 2, or 3, you still have the same survival as people without prostate cancer. And this is national cancer. It's only stage 4, which is relatively rare, that has a bad prognosis. So the fundamental reason for screening doesn't apply to the vast majority of men who get diagnosed without screening, because they get diagnosed in these stages. 2 randomized trials. The one from the US showed no decrease in prostate cancer. As a matter of fact, there was an 11% increase in deaths. This was not significant, but it certainly says, wow, they didn't prevent any deaths. The 13-year data have now been published and show the same thing. So this big old trial, okay, just like the mammography trials, showed no effect. That should be enough to convince most people. It was enough to convince the American Cancer Society and all that. But as I say, it's going to be a slog getting the public to understand this. There was an increased cancer burden when you screen these people in this trial. A European group did show a reduction in prostate cancer deaths, but it was overwhelmed with the new cancer burden that you were providing, with a doubling of the number of men who were being diagnosed and treated for prostate cancer. So these 2 studies together were used as very strong evidence against PSA, which is why all the organizations now, none of them are recommending it. Still, this is PSA testing in Texas. Before any of these studies, no one would recommend screening for PSA in these 80 groups or 85 and over group, and yet 40% of Texas men were getting screened every single year, 40%, and it was going up over time. So this is scary data. Colonoscopy, one of the great breakthroughs in terms of reducing the actual incidence of a very important and common cancer. About 4% of people will get colon cancer sometime during their lives. Some of the risks with all cancer screening is sort of creating a cohort of worried well. The reason this is important with colon cancer is about 50% of people are going to have a polyp. 50% of people in their 60s are going to have a polyp. So if you get screened and you get told by your doctor, you have a precancerous lesion, for some people that says a lot. They sort of walk differently from then on. That's not, and any healthcare providers have to be very, very, very careful of how we communicate this information, because you can create neuroses with this information. Very rarely can you have serious complications. 1 in 1,000 will result in hospitalization. 1 in 10,000 will result in death. So 1 in 10,000, that's not much. Yeah, right, but once again, only 4% of the people are going to develop it to begin with, and most of those people would have survived without it. So it begins to add up. The major problem is too frequent use. No one is arguing against colonoscopy, but we are arguing against using it more frequently than you should. This is a natural history of a very, very large polyp. If you have a big 1 centimeter polyp in your colon, which is huge, then even after 10 years, less than 10% of those people have developed cancer. So the current recommendations is if you have if you're clean, if your colon is clean, then you should have it every 10 years. And it's based on this type of information, that it just takes a very long time to develop into cancer. Here is the fact that there's a lot of overutilization. So here in these areas in the country, some of which are in Texas, more than half of people over 65 are getting a repeat colonoscopy earlier than they should. And everywhere in the country, at least 20% are. So back to the recommendations. Prostate, oh no, these are old. Oh, that's terrible. So anyway, these were 2 years ago recommendations. Right now it's do not screen. Any age, do not screen for U.S. Preventive Services. For colon cancer, don't screen over age 75 because of this very long history of slow progression from a polyp to a cancer. And in mammography, they've changed from yearly to every 2 years because it cuts down on the false positives. Well, we don't have to get into why they don't like women 40 to 50. It has to do with the fact that there's a lot of carcinoma in situ that tends to go away on itself, and so that's why they feel that, as opposed to colon cancer and prostate, where most of the overdiagnosis is in the older you get, the more likely you're going to be overdiagnosed. With mammography, it's actually women in their 40s who are at higher risk for getting diagnosed with something that would go away. And that the ACS is sort of coming around to the same picture, so we don't have conflicting stories. Thank you.